Hi, everyone. It's me again. Going to ask you to start to return to your seats. And we're going to continue on. Raise your hand if you feel any more relaxed after our afternoon sessions. Does anybody feel any differently? Oh, yes. A couple people are raising their hands. Good. Kimberly Boynton, are you still here? I owe you some money. You paid twice, right? Okay, I'm gonna give you the money back. Kimberly, did you pay $80 total? How much total did you pay? 80. Okay, so I owe you 40. Okay, good. All right. So I'd like to introduce our next speaker. While I'm waiting for you guys to settle in, I'm just going to remind you that July 28th is the Miles for Migraine Walk Run. And I hope that everyone in this room will consider coming. And if you are not feeling well that day, bring a lawn chair and just show up and be present. You don't have to walk. You don't have to run. Just show up and show the world that you're advocating for our disease.
Where is it?
It's going to be at Chrissy Field. And the website should be up. I think it might be live to sign up. You'll get an email. You're all now on our email list, so you can get our newsletter and you'll get more information within the next month. And also, I'm going to just remind you that you'll also be getting a survey after this event. So please take a few moments to fill it out because we want your feedback. We want to do this next year. And we'll change the format a little so it won't seem redundant. So I want to introduce you now to, not to Dr. Cowan, but instead to Dr. Rebecca Michael. She is an assistant clinical professor at UCSF Headache Center, and Dr. Michael earned an undergraduate degree from the University of Southern California and her medical degree from University of Nevada School of Medicine. She completed her neurology residency and headache fellowship at Cleveland Clinic in Ohio. Her research interest includes the relationship between sleep and headache and the utilization of services such as telemedicine to improve outcomes of healthcare delivery. So please welcome Dr. Michael.
All right. Well, thank you all for being here. Although one of my interests is sleep and headache, hopefully this lecture will not put you to sleep. It's an exciting time in the field of headache, and I'm really fortunate to be able to discuss this topic with you. I'm not Dr. Cowan, but I do have actually some of his slides from the lecture he was intending to give incorporated into this lecture. So you'll get both some of his ideas as well as my ideas on what the future of headache medicine is going to look like in the next 5 years. So has anybody ever seen this structure before? No. So it's actually, I thought this was pretty beautiful and fascinating. It's a Mexican architect, Javier Senocian, out of Mexico, whose architect is based on concepts of organic architecture, bioarchitecture, and he creates things that look like nature. And this is actually a shell. And I just use this picture to illustrate that I know a lot of you may feel like with all of the disability that comes with chronic migraine, the vertigo, the nausea, you do have trouble functioning. You may feel like you're living in a shell. And this is literally a house. Somebody's living in a shell. And if you have been living in a shell, or if you haven't heard much of the news of what's going on in the field of headache medicine, you may have missed that there's a lot of headlines right now about all of these new drugs that are coming out for migraine. And these are just a few of these headlines. That's NPR. This is some local news. They're called the CGRP monoclonal antibodies. Who's heard of CGRP? Okay, so about half of the people here in the room. And then, of course, Ferris Bueller, a great quote, "Life moves pretty fast. If you don't stop and look around once in a while, you could miss it." So in case you have missed some of the information about CGRP, what is it? What does it stand for? Well, it's a calcitonin gene-related peptide. It's a small neuropeptide that's found throughout both the brain and the body, and it's highly prevalent in the trigeminal system. And the trigeminal system is thought to be one of the main areas involved in the pain processing of migraine. It's found in the brainstem. And so CGRP it's really prevalent here. Researchers in the 80s discovered that there are high levels of CGRP in migraineurs suffering during an attack. And if you're adequately treated with a triptan, those levels decrease. It's also thought that some of the mechanisms of Botox work on this CGRP neuropeptide. So why is this exciting? Well, CGRP is now this new target that we have for pharmaceutical drugs. And that's really exciting because the last time that a medication was specifically designed to treat migraine were the triptans about 20 years ago. So this is the first time that we've seen in a long time that we're developing something specifically geared towards migraine. So there's two different classes of medications that are targeting CGRP. The first was actually these small molecule CGRP receptor antagonists. That's a mouthful. You could also call them the GPANs. And those were actually initially starting to, they were being developed in the 90s, the early 2000s. But they were halted because there was some issues with making them in an oral form as well as some liver toxicity issues. However, more recently, there are three more that are in development right now, in the earlier stages of development: abrogepants, rimegepants, and atogepants. What you've probably heard a bit more about are these monoclonal antibodies, and these are immunotherapy. They're being used, monoclonal antibodies, in other areas of medicine, in oncology, cancer. They're also being used pretty prevalently in other neurological illnesses, multiple sclerosis, and now migraine is no exception. So there's 4 of these that are currently being developed by 4 different pharmaceutical companies: eptinezumab, galcanezumab, fremanezumab, and erenumab. Say that 3 times fast. And so this is what we'll focus a little bit on. So what will the headache landscape look like after these medications come out to the market? Is it going to be like Bambi, innocent, curious, happy, everything looks great? Or is it going to make things a little bit more problematic, a little bit destructive? I don't think it's going to be this black or white, but it's definitely something everybody is thinking. One of the main questions are these really going to be a game changer? How different are these? Are they really going to make that big of a difference? Well, there's 3 things that I think we need to look at. They must be as good as a lot of the marketing has shown and says that they are. There can't be any post-launch surprises. And they need to be accessible. You all as patients, it would be nice if could have easy access to them. So how different are they from current treatments that we have available? The efficacy in the clinical trials, it does look like it's similar to Botox in terms of the reduction in the severity and the frequency of pain. But something that is unique is that there has been shown to be a significant early benefit. In some studies, as early as even the first day, as well as within the first week. And I think this is significant because this will help us understand sooner whether this treatment would be something that's appropriate for you. What we have right now are medications that can take up to 3 months to know if you've had full benefit. Botox, we like to go through at least 2 treatments. That's 6 months until we know whether or not it's working. It seems like from the clinical trials, these have efficacy earlier. There's also what we would call super responders, so a small percentage of the population that was studied showed that they had a really significant decrease in the number of migraine days that they had, almost 100% in a 6-month period that was studied. Again, that wasn't everybody in the majority, but there are this small population that are really responding to these. The side effects are mild, and they seem to be fewer than anything else out there that we have right now. Something else that's different, though, is that similar to Botox coming in every 3 months, these will be either actually monthly injections or one of the pharmaceutical companies, it's an IV infusion that will be every 3 months. So there will be a requirement to get repeated dosing. So how likely are the surprises? Well, that would be post-launch safety issues. If there was any unanticipated drug-drug interactions, if there's any populations that are more at risk for having side effects that weren't identified earlier on, those would all be some of the surprises that we would look out for. But like I mentioned, in terms of side effects, from what we know so far from the clinical trials, there are minor few side effects that we've seen, the most frequent being some injection site pain, upper respiratory infection or nasopharyngitis, a little bit of nausea, dizziness, but again, mild side effects. But in total, with these clinical trials, there have been less than 10,000 patients who have gotten these monoclonal antibodies thus far. Something to keep in mind is that there have been medications. Some of you may have recalled some of the issues with these, Vioxx, Cylert, Permax. Once they came out to market and wider distribution, had cardiac issues or liver toxicity. So that's always something we like to consider when we're thinking of new drugs. And then the effect of these monoclonal antibodies to CGRP in humans, it's unknown with certain aspects of brain injury, MI, and stroke, which are a lot of the patients that we see, especially the brain injury. There's some thoughts that we know CGRP actually plays a role in the blood vessels, can help with vasodilation. So that's why understanding the risks in this population is important to know.
Could you comment on the bottom? It was saying something about metabolism and the endocrine footnotes. Looks like there's some study.
Oh, that was just the paper that some of this information came from.
Oh,
Yeah. But I'll happily take questions at the end if you had any specific ones about that. So access. I know this is a question I was even talking to somebody about this morning. Are you going to be able to get these? Well, there's definitely going to be step edits by insurance, meaning something that you already go through now with some medications or even Botox, having to try one thing first, then something else, then something else. It's likely that that's going to be the case with these as well. The absolute cost, how much are these really going to cost to you as patients after marketing and everything that goes into developing these. And then also supply chain challenges. There's obviously a huge demand. You saw some of the epidemiology this morning with the number of patients who have migraine. A lot of people suffer from migraine, so kind of like this cartoon, the demand might be a little bit more than the supply. Why is just substitute gas with CGRP so expensive? So I'll take note, this isn't my slide. I hope the back doesn't throw stones at me. Pharma can be philanthropic, but again, it's not a philanthropy, and we all know that a lot of medications can be expensive. So the monoclonal antibodies, they're likely going to be priced somewhere between what we know the onabotulinum toxin and the current monoclonal antibodies that are out right now for other neurological diseases. Just an estimate, at least $8,000 a year. Again, it's unclear, but that's just an estimate. And so unless they're priced below onabotulinum, it is unlikely that they're going to be widely and easily accessible to patients. That's just realistically. And they're biologic agents. So creating generics is going to be unlikely and very difficult. So when it comes to how are we delivering these medications, that's also something that's important to keep in mind. Something about injection sumatriptan, when that first came out to market, there was actually evidence that there was clear superiority in its effectiveness for patients to other things that were available, but it didn't do as well, even despite that. So who knows if that might be the case with these as well in terms of having to come in for an injection. Again, we don't know exactly what the process of having to come in for these injections or the infusions are going to mean for you as a patient or even for the delivery systems of us as providers. Is the neurologist that you're seeing currently, are they going to be able to even give these to you? Are you going to have access to a system that would be able to give these to you? A lot of this is unknown and things that we just have to keep in mind when we're thinking of how these are going to be distributed. So some predictions. We do know that these look promising, that they are going to open the doors for select population, that understanding how these are working in migraine patients in these populations is only going to yield more novel treatments and help us to understand further the pathophysiology of migraine. And these new treatments, I think, are just going to continue to alter the culture, the economics, the clinical approach. I liked this picture. One door is going to open another door to another door to another door. Other than these monoclonal antibodies, there are a lot of other things that are being discovered about migraine and a lot of other things that are currently in the pipeline. This slide is a little bit overwhelming, but that was the point. Some behavioral treatments, which you've heard a lot about. There are some other things that are also being studied: acceptance commitment therapy, the mindfulness-based stress reduction, cognitive behavioral therapy. There's a new triptan that I'll talk about in a minute. We're learning more about ion channels that are involved in migraine as well as targets genetically. There are more neuropeptides and hormones other than CGRP. PACAP is something that I think you're going to hear a lot more about. There's a lot more research that's going on about the role of PACAP in migraine, as well as orexin is another one that is being studied. And then neuromodulation, which is something that Dr. Levin touched on this morning, but is another really exciting area of migraine that I'll talk about. So both the new triptan and neuromodulation. So triptans, like I'd mentioned, that's the last time a medication came out that was specifically geared and created for migraine, and that was over 20 years ago. So there's a new class, it's called lasmiditan, that's currently in its phase 2, phase 3 clinical trials. It's another serotonin receptor antagonist, which is what the other triptans that are available are, but this works on a different receptor. It's for, again, acute treatment of migraine. There's been positive results so far, and one thing that's of benefit is that if you have any pre-existing conditions, vasoconstriction or heart disease, a history of stroke, the 5-FT1F receptor is thought to not cause vasoconstriction, so these would be safe in those types of populations. So neuromodulation, how does it work? Well, there is a lot that we still don't entirely know about the pathophysiology of migraine, but from what we do know, and even things that were discussed this morning, there are different areas of input that come into this. Is there a pointer on here? Yeah, that's okay. Inputs, cortical spreading depression that then come into the trigeminal system, which is in the brainstem. And neuromodulation is thought to come on to different pathways and to help inhibit or modify some of those inputs so that it decreases the pain. So this just kind of shows the the changes in the incoming pathways. So there's 4 devices I'll mention. The first is transcranial magnetic stimulation, then the supraorbital transcutaneous nerve stimulation, the vagus nerve stimulator, and then the last, SPG, sphenopalatine ganglion stimulator. This one is not approved for migraine yet, but it's been approved for cluster and maybe sometime in the future for migraine as well. So some of you may have this device or have at least seen it. It's called the transcranial magnetic stimulation. It works through a magnetic pulse. It's approved by the FDA for both acute and preventive treatment of migraine. You can see here on the left is a patient demonstrating how it works. On the right, there's a new device that just came out that's a little bit smaller, a little bit easier to carry around. But this can be used both. It would be twice a day as a preventive treatment, and then you can also use it during an attack for acute treatment. The next is the supraorbital transcutaneous nerve stimulator. Some of you may have seen this or may have this as well. It was previously just approved for the prevention of chronic migraine, but recently was also approved for now the acute treatment of migraine as well. So there's a device that has the ability to do both. You can use it and put it on when you're having a migraine for about an hour. And you can also use it then every night as a preventive for about 20 minutes. Then the vagus nerve stimulator, this was something that was initially just FDA approved for cluster headache, but at the end of January, so just recently, also became FDA approved for the acute treatment of migraine. This works actually it's a vibration on the vagus nerve, which again goes into what we think is the migraine pain processing generator system and helps modulate that and decrease pain. And then the last one, like I'd mentioned, it's not approved for migraine. It's only approved for cluster headache, but it's a device that works through the SPG ganglion, which is also thought to be involved in migraine. And so maybe in the future, this might be another target for the treatment of migraine as well. So just a few other things that also may change the migraine landscape in 5 years, just identifying further different types of migraine subtypes. We all know that migraine patients, you share some features, but you're all very different. And being able to determine different features of migraineurs, whether it's through genetics, through different types of imaging, modalities, or through biomarkers. I think that would help us as providers understand which treatments work better for which populations, including behavioral treatments into our standard of care. Like I know was mentioned before, it's not going to be the one sole part of your treatment, but incorporating it into other treatments like Dr. Jackson showed, when you incorporate some of the behavioral treatments with medication, tend to have better outcomes. Doing things more in a process-based system is also potentially in the future. I know right now you see your provider, and we're trying different things based on you as an individual, which does work, but there might also be future options to standardize some things or to come up with better algorithms. And then I think advances outside of headache medicine, especially in the fields of technology and gene therapy, are only going to reframe the migraine landscape as well. So just kind of in conclusion, there's definitely a lot of factors at play. One being pharmacological treatments, the CGRP, monoclonal antibodies, the GPANTs, the new Triptans, the non-pharmacological treatments, neuromodulation, behavioral strategies, and then a lot of things that are unknown but yet to be discovered, some of the other neuropeptides, genetic treatments, a lot of things that are in the works. But I think it's really going to be a combination of these things that give us such a hope for the future. And I thought this looked like an emoji, but a little bit more futuristic, which is why I liked that. So I think that the best is yet to come in headache. I know it's a reason why I went into the field of headache. I think that there's so many things that are exciting and coming out. So thank you for your time.